Welcome to the Royal Australian and New Zealand College of Radiologists' 90th anniversary podcast series, where we celebrate 9 decades of excellence in radiology and radiation oncology. In this special series, we honour the remarkable careers, achievements and contributions of our members who have shaped our college and the profession. Today we're delighted to feature Professor Michael Sage, whose dedication and service to RANZCR have left an indelible mark on our RANZCR community. As a life member, Professor Sage has generously volunteered in various roles over the years, contributing his time, expertise and passion to advance our mission. Notably, he served as President from 1997 to 1998. In this episode, Professor Sage shares his highlights of his illustrious career and the achievements he's most proud of. His journey exemplifies dedication and excellence in clinical radiology. The stories and insights he provides offer a unique perspective on the evolution of the college and the specialty. We're honoured to share his experiences with you in this podcast. We hope you enjoy listening to this episode.
What first interested you in a career in radiology?
That's a very good question, Eva, because back in the 60s, radiology wasn't really regarded as a very prestigious specialty. It was regarded, it wasn't really highlighted to us as medical students, or none of our really physicians and surgeons were the dominant people, and the other people certainly I was encouraged to become a physician by my teachers. And part of the physician training down at QEH where I trained, we spent a year in pathology where we went and did autopsies back when they did autopsies. Of course, CT and MR have changed that a lot, but we did a lot of autopsies and we did a lot of looking down a microscope, and it was really quite an exciting year in some ways, although not clinical, obviously. And part of the week we would demonstrate our findings to various clinicians and show X-rays. The radiology registrars would come up and show X-rays while we presented our findings. And so I really became interested in pathology and the correlation with radiology. And I also found a lot of clinical medicine, shouldn't say stressful, but I found I was on the renal unit the year before, and it was the days before it was very, very crude days, early transplantation, you had patients, and so I thought, not sure I want to be a physician, although I must admit all my senior physician mentors were very upset when I was thinking this way, and anyway, I thought, I don't want to be a pathologist, I want to have a little bit of contact with patients, so I thought about radiology. And I went and talked to Bill Tucker, who was the director down in the X-ray department at the QEH, and he was very positive and encouraged me. I still was under a lot of pressure from my senior consultant physicians. They really thought that I was giving up medicine. And I found that quite hard, to be honest with you. A lot of people felt that radiology wasn't the right career for me, but I stuck at it and I'm thrilled that I did. And of course, since then, radiology has become much more important, particularly the CT and MR. But I really went into it because I enjoyed pathology and I wanted a little bit more. And radiology is really, at that stage, was, if you like, pathology on celluloid, and you've got very good clinical correlation. You dealt with the clinicians, and in many ways you were the clinician's specialist. You were much more needed than people gave you credit for. So that was really why I did radiology. Although I must admit at the time it was quite a stressful decision because of the attitude of a lot of my clinical mentors.
You've held a numerous roles within the college, including Chief Censor and President. Do you have any memories regarding the challenges and achievements of these roles that you'd like to share?
Well, certainly when I first started getting involved in the college, it was much more informal and much more collegiate in some ways. At a local level, we'd have a branch meeting, and because we were smaller in number, they were well attended. The scientific meetings were well attended. We really knew everyone in the local branch. Of course, the numbers have made that difficult. Then as I got involved in the college, I really enjoyed that. It involved getting to know radiologists in other states who had an interest both in the college and in academia, teaching and research. And so I really enjoyed the camaraderie of my colleagues interstate and from New Zealand. And in fact, it was a wonderful way of making some close friends, which I still have. And I must admit, I thought the college the informality was probably, I find now with all of the modern technology and the college has expanded a lot. I think the floor space is now 3 times what it was when I was president, which isn't that long ago. The number of staff is very large. And I really enjoyed getting to know the college officers. There weren't many. There were less than there were now. We had Julia, we had different Liz Rookie, we had a very small number of office bearers in Sydney, and we got to know them very well. And so I really enjoyed the atmosphere of the college, which was much more, I think, informal. And I think we did a lot more work without recognition, which was good. We beavered away there. The college meetings were always organised at a local, they rotated from each state, and someone would be nominated as the convener, and then you'd have scientific conveners. And that was done on a fairly informal way, but really worked very well. I think people really felt as though they were very much involved. So I think that's the change. I feel that the college has become much more bureaucratic, should I say. Now, that's probably keeping up with the fact you've got to get me to sign a bit of paper to take part today and this sort of thing. I know that's the way life is, but certainly I've seen that. My biggest achievement, I think, was when I was chief censor, or in those days we'd call the warden of the membership, and I took over from Jim Syme. And again, he was sort of a historical character in the college. You'll come across his name many times. Wonderful fellow. Only trouble is Jim didn't keep very good records, so I had to really, for one, start the college, the student records. But we managed to beaver a bit, to gradually become more professional in that area. And I enjoyed the exams. I'd organise exams. I'd invite various people from around Australia, senior colleagues, to become examiners. Early on it was very, very simple. We simply had a written paper, an oral film reading and an oral examination. And that, of course, expanded, and I guess I was involved in that expansion. The expansion was required really because of the increase in the number of modalities that we have. I guess the first one was paediatrics. We thought we had to have a separate exam in paediatrics. Then along came mammography. It was felt we needed a separate exam in that. It gradually expanded from one oral to, I think it's now 10, is it? I'm not sure how many it is now, but it's 8 or 10. And again, the number of examiners had to expand. People at that stage felt it was an honour to be an examiner. I get the impression that sometimes it's harder to get people to participate, which is disappointing. I think when we were asked to be examiners, we felt it was an honour to be asked. It was a recognition that we were perhaps a senior leader in a particular area. In those days, initially, it used to be in Sydney or Melbourne. I expanded it here down to have it here in Adelaide, purely because logistically it was difficult to find enough space. I was able to get permission to use the outpatients at Plymouth Medical Centre, so we were able to have multiple rooms, ran it on the weekends, and it worked very well. Then, I think it was still when I was still warden, we moved to the hotel next to the college, which worked very well, where Julia, get Julia's surname.
Snick?
Yes, Julia was wonderful. Anyway, Julia, and in those days my 2 secretaries from Flinders worked with Julia. That's all we did. They They would write to people, invite them to be examiners. We'd book the hotel, book the rooms. Julia would get the viewing boxes into the various rooms, and we ran pathology actually in the college office. And that worked and I think that may still be the way they do it. And it worked very well because, the college Julia could contribute to it and be involved, and other college members. The other thing is there was a move to get rid of pathology at different times, and I fought that very strongly, because I think that if pathology to me is the backbone of radiology, we're one of the few colleges I know that actually hasn't examined pathology. Other colleges do. I think in America they go and do a course at the Armed Forces Institute, but we actually examine in pathology, and I think that's very important because number one, medical student courses these days don't learn pathology we learned, so it's even more important that we do pathology. They just don't have pathology at the depth. I think it probably applies to all medical schools now.
Yeah, wow.
We really learn pathology in great detail. So, the pathology is still a very important role. We went from POTS, we used to show them POTS, just like our medical students, then we went to photographs more recently. I think that's still the way they're doing it in the college office. So I think one of my achievements was to gradually move from one oral into 8 or 9 orals, to change from a rather ad hoc arrangement in the various hospitals where we run the exams, outpatients at Flinders, to having them more formally next to the college. What's the hotel called? Next door. And I think that's still the way it is being done. A disappointment for me is to hear that they often struggle to get examiners. That may be wrong, but the numbers are much greater now. You need 3 per, much greater. The registrar, the numbers being examined is greater, the number of orals is greater, and people are more busier these times to give up time. But I hope people still feel it's an honour to be asked to be an examiner for the college. Yeah.
That's wonderful. Could you share your memories regarding the challenges and achievements as president after being an examiner?
Well, president in those days wasn't, we had a council, we didn't have a board, and we only were president for 1 year. All right. Now, what happened was the college, and this has been a big change, and I'm not sure it's a good change. The president was elected at a local level to be president of the college the year that the meeting will be held in their city. All right. So 2 years before I was president, I was elected by the local South Australian branch to be president. That had to be obviously approved by the council. And then I was president for that meeting here in Adelaide. So there's a rapid turnover of presidents. The negative thing of that was, of course, obviously their relationship with the CEO or their relationship with the head office was often much more superficial. I think it's probably, we had to move on. We had to go, it's 2 years or 3 years now?
2 to 3 years.
2 or 3 years. I think that had to happen. But again, it just simply reflected the more informal branch level activities. All you did was chair the other thing that's changed also, at that time each branch, like the Federation and the states, each branch had their own councillors. So for example, New South Wales would have 4 councillors, Victoria would have 4, South Australia would have 2, Perth would have 2, Queensland would have 3. It's based on volume. So, and again, our councillors were elected at a local level, all right? So there were people you knew, and the other point was that the state branch knew each other, and therefore they wouldn't elect a councillor they didn't respect. They didn't know them. Whereas now you tend to get a bit of paper saying that Eva so-and-so is so-and-so, she's been this, this and this, and I may never have met you. It's right. More of a... But that's moving with times. We were much more informal. So the councillors were elected at a local level, but met in Sydney. And they could be, I don't know how long their terms were. And the president was appointed at a local level. Usually the president already knew a lot of the people interstate. It was very much, the council was much more informal. We did meet and we had minutes and the rest of it. no more, probably the meetings were just as formal as the board is now. But each state felt more involved in the council and the board. I think if you ask some of the younger South Australian radiologists now who even our president is, they wouldn't know. If you ask them who the councillors were, they wouldn't necessarily know. Whereas when in the past they knew who the councillors were because they used to complain, they could go to their local councillor. I'm not rejecting the new board structure, but I believe it's taken away some of that collegiality that we really had. Now, I guess once I retired, I had less, I still go to the president's dinner, etc., but I don't have much to do with it. Just the feel that the radiologists I do have still, I ran REPAD until last year, etc., I had a bit involved. I didn't get the impression they ever mentioned the college much, and if I mentioned something, they weren't sort of involved. But I think that's just progress. It's happened in all boards, hasn't it?
Yeah.
And this faculty structure they've got now is we're getting deans, and previously we really had, there was the president, councillors, warden of the membership or chief censor in both specialties, and an editor, honorary editor with 2 editors. They were really the main office bearers, and that's changed. And it had to change, you've got to move with the times. But I was happy to be involved back when I was involved.
Wonderful. You've won many awards, medals and prizes. Of which are you most proud?
Yes, I noticed that on your list. I think they just come up at a time. As my wife Helen's not very keen on awards, because I think that in fact everyone, it's like all these things when you see it. But probably the one I was most proud of was honorary membership of the Radiological Society of North America. At that stage, we now have a much closer relationship with the RSNA. Remember, their president often comes to our meeting. Our president goes to that meeting. But in those days, your international reputation came more from presenting at meetings. You'd go to the RSNA and you'd present, or the ASNR. So I'm very proud of that because I think I was able to get to know and get a reputation internationally. From an ego point of view, I'll just read what the award was at that time.
Absolutely.
Because this is history, I'll be dead by the time someone's reading this. I got to know a lot of the people over there and sung from the supper, and I'd worked being on sabbatical leave at various universities. So I was very pleased to honour membership because there's I think 3 Australians have got it, Bill Hare, Jeff Paness and myself. And it just says here what the President said, but they read this out and it's all very formal. Internationally recognised radiologist, administrator and leader in the Australian medical community whose influence and leadership in radiology have extended far beyond his native Australia. So I felt that was, if you're talking about pride or ego, that was the one that did make me feel, oh, that's pretty good. Most of the other awards that I've got through the college, the other award, again, it's historical, and this is not going to be printed, is it? This is an oral history,
fine,
yeah.
yes.
Was when I topped the exam in England, because what used to happen is we'd do our diploma here, and then if you wanted to get on further, you'd go and do the fellowship of the faculty of radiologists in England, and it was so I went over there, and there were about 400 people sitting for it, and when they announced, when we went and got our certificate, I was standing in the back, and I was going to just sitting there, sort of blah, 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 and they announced my name as the winner of the whatever medal it was, Ryan Williams medal, and I wasn't even listening because I didn't know, and so they had to announce it several times because but I was pleased to beat the palms, if you like. And in fact, when Professor Robert Steiner, who was the president of the Royal College of Radiologists in England, presented to me, he said, "This doesn't give me great pleasure." But I think most of the awards in the college have been I've appreciated very much getting them, and I think I enjoyed being the Rouse Fellow to New Zealand. I've always loved New Zealand. I've always loved the New Zealanders. And again, that helped me to get to know some very wonderful New Zealand radiologists and who I still regard as friends. So, yeah, the honorary membership of the RSNA is probably, if you're talking about if you talk about pride, which my wife's very upset about if I ever talk about pride, it would be the one, yeah.
Would you like to share any memories specifically regarding the development of radiological equipment and technologies?
Yes, I've been very fortunate to come up because although I quickly got over the ego business of physicians telling me I was a failed doctor, I quickly got interested in neuroradiology. The beauty of neuroradiology in those early days, it was very crude even, very crude. What we did to patients was really quite horrific in some ways, but there's no other way because of the skull. It was difficult to get, and we're getting only secondary information about brain tissue. What we did was we would inject dye into blood vessels and show the blood vessels. And we'd rely on changes in those blood vessels to see if there's any pathology in the brain. Or we'd do a very nasty test called an aeroencephalogram where we'd put a needle into the spinal CSF and squirt air in it, would bubble up around the brain, and again, not actually show the brain tissue, but would show the ventricles inside the brain and the surface of the brain, and we'd rely on changes. We'd rely on normal X-rays, the air is very low, and we'd pick up the air against the skull. So neuroradiology was a real challenge, and not many people did it. And again, we got a bit of a little group of us who were quite keen on this, although it was very crude and not much fun for the patients. So I got very interested in neuroradiology because it was really quite a academic activity. You're looking for minor changes in blood vessels, and you look for changes in the air CSF pattern. We relied on that. And so I went over to London. I got to go to the National Hospital for Nervous Diseases to get more experience in angiography and aeroencephalography. Well, within 6 months, they installed the second CT in the world in the National Hospital for Nervous Diseases. And I remember the excitement. There was a kid in the Great Ormond Street hospital next door who had a big head. Now, in the past, if a kid had a big head, you would have done an angiogram to see if where the vessels were stretched, because big head was usually due to what's called hypercephalus, big ventricles, something that's blocked in the drainage of the brain. So the head was... So you do that, then you do a burr hole probably, or an aeroencephalogram, where you'd shove this air in, you'd speak to the parents, you'd say, we're going to put a hole into Johnny's head, we're going to put a needle into his brain, and we're going to inject some air, and blah, blah, blah. Imagine how traumatic it was. Yeah. Anyway, and so the kid would, you can imagine how... Anyway, on the fourth study ever done at Queen Square was a fourth CT scan. Kid's head had anaesthetic in those days, went into the scanner, out came this, what now is a very crude picture, but there were these big ventricles, and there was the CSF, and there was we worked out what the obstruction was at the aqueduct. So the kid had been spared an angiogram, he'd been spared a aeroencephalogram or a ventriculogram, and parents were spared the trauma of all of that, and there was the diagnosis. And it just blew us away, just blew me away. And the other tragic thing was, I was at that stage writing a manual, I was preparing a manual on vertebral angiography, which is the vessels at the back of the brain. I threw it in the bin. I realised overnight that what had happened was the need for detailed angiography, and aeroencephalography disappeared, the need had totally disappeared, thank God, and the need for detailed angiographic details, at least at that stage, was probably going to become less. And that was just an exciting time. And so what happened in those days, you had to shove it took about, each cut of the brain was about an inch thick. It took about half an hour to do the study. The actual digital images are made up by little pixels, dots, you probably know that from little dots. And the dots at that stage were quite large. You could almost see that each pixel. That's gone now to the cuts are about a few millimetres or less. The speed is almost instantaneous and you can't see it. So the technology's advanced. But having said that, those early CTs were just exciting. So I think that's probably the most exciting moment I had in radiology, was to see that CT come out and show those big ventricles in this young child. Yeah.
I can imagine witnessing an event like that just drives you to just keep doing what it is that you do as well.
It is, although you can see why it meant a lot of the knowledge which I was there to achieve, to find out on angiography, and was going to become less important.
And yeah, almost obsolete.
But now it's become again important because of interventional neuroradiology, but that's much later, 30 years on from that. Yeah.
Would you like to share any memories regarding your involvement with the college or the developments in radiology you have witnessed over your career?
Well, probably that what I've just mentioned is probably the most important thing. I think that's what I've witnessed really, and that's changed. What that meant was that the radiology suddenly became much more obvious, because from CT in the head, it's now expanded the whole body. And so suddenly CT has become the modern chest X-ray, if you like. That many, I don't know what percentage of patients going to a hospital would have had a CT or now an MRI, majority. So that's one of the other advances. The other major advance has been ultrasound. Ultrasound early on was mainly Doppler type studies for blood flow and this sort of thing, but now, and Australia played a important role in the development of ultrasound. Dr. Garrett and George Kossoff, names you would have in the college, would be in the college archives anyway. They pioneered, so Australia really were pioneers in the use of ultrasound, particularly in obstetrics. And so ultrasound has now got its major role, particularly in obstetrics and gynecology. It's really become very important in the biliary tract. In fact, it's very important, but not quite as accurate in many areas as CT. But I think you'd probably, if you were suspected someone had gallbladder disease, you'd do an ultrasound before CT. If you suspected they might have obstructed kidneys, you could do an ultrasound. And the beauty of ultrasound, of course, is you don't have radiation. So now it's very important in paediatrics. I always often said to the medical students that ultrasound is a paediatric friend. Well, not only just radiation, but it doesn't like fat, all right? Whereas CT is the adult, because it loves fat. Because what you rely on is CT, different X-ray absorption, and fat gives you a nice, if you like, border for the various organs. So ultrasound is really, its use has been expanded. The other area, I think, probably involvement with the college and development has been interventional radiology. In the past, we were very much involved in doing barium mills and barium enemas and general angiography, diagnostic angiography. Then it was found that you could use radiology techniques, or you could use imaging to do various procedures. So a specialty of interventional radiology developed. And radiologists in Australia, people like Ken Thompson and other people, played a major role in developing interventional radiology. For example, its role was in blood vessels. If a blood vessel was narrowed, you could put in a balloon and blow up the stent. You blow up the narrow. We put a stent in. What's happened, unfortunately, and it's happened in the neuro area, is that we took away some of the surgeon's work. So what's happened is we sort of pioneered a lot of interventional studies, but you had to be a particular type of personality to do an intervention radiology. There was risks, and because people were able to do CT, MR, ultrasound, and make a good living out of that, if you like, to get young people to do intervention radiology, they have to be really dedicated, and you need a certain volume of patients. You need a cohort of patients. So it was done very much in the teaching hospitals, really. What's happened more recently is that the surgeons, for example, in the area of vascular intervention radiology, have realised if they don't do it, they'll have no job. So what's happened, and they have the patients referred to them. And what's happened is that now a lot of interventional angiography is done by vascular surgeons. The other area that's happened is in neurology. In neurology, when the kidneys were blocked, we'd be called in to do an antegrade parallelogram, or we'd be asked to do other procedures. Now what happens is the urologists do most of the renal intervention radiology. They'll do put a cystoscope in, and they'll thread their guide wires up, and they'll do the work that we used to do. We're still asked to do antegrade parallelograms when they can't get in. But see, the problem is if they take over most of the work, it's hard for a young person to be encouraged to go into that specialty. And there's still turf battles going on now. The area where we're still number one is probably interventional neuroradiology, where we thread catheters up into the brain and put coils into aneurysms in the brain. But even there, I think we go, in the US particularly, we're gradually going to lose that. Hopefully we won't, but because they have the patient first, in fact, quite a few neurosurgeons here in Adelaide have gone into spine surgery, I believe, because the vascular work has been taken by the neuroradiologists. That was pioneered very much by Ab Simon and Mark Ganguri in Perth. And so we do most of the subarachnoid hemorrhage treatments now, whereas previously, but the beauty of it is that you save the patient a craniotomy. So the battle for interventional radiology is still going on. I think sadly, we're going to, and people get very upset when I say this, we're gradually going to lose it, because I look at my interventional radiology colleagues and said, now, if you're a vascular surgeon, you'd be into that, wouldn't you? Well, yeah, I guess so. And if you're a neurosurgeon, you'd be into it too. And they can't, it's the way things are. Yeah. Well, the other thing, I guess, from memories regarding your involvement with the college is what I mentioned earlier, is I think that I think the college, and please don't take this as a criticism, this is a history anyway, isn't it?
Absolutely.
I think we've gone from, when I first, we used to have where's the college office now? In
Druitt Street.
I'm trying to work out what it's like for. Well, when I first was involved in the college as a counsellor, it was in Lower 4th Street under the bridge. And you walked in, you had about 3 little rooms, you had a little tea room, and Liz Rookie would be there, and your council room was underneath. And we've gone from that. And then we went to Druitt Street, and we had that one area, and the cricket club was next door when you came up the lift. We seemed to have plenty of space, I thought, in there. Now they've taken over the cricket space, I gather, and the number of staff has increased. And I think that's great, that we had to expand, but to me it took away that sort of informality which we had. So the expansion of the, if you like, the bureaucracy, you could call it whatever, the administrative aspects of the college has been exponential in the last, I reckon, 15, 20 years. It really has expanded. And whereas I'd go in there and there'd be Julia and there'd be someone, and I'll give you an example. When I was editor of the college, editor of the journal, it was probably a bit too ad hoc. I was here in Adelaide, and I had someone who was half-time or less than half-time, and I'd drop into Sydney once a month and we'd go through the papers and I'd send them out, and it was all a bit sort of ad hoc. But it's much more formalised now, but I don't find the journal is any more professional. Do you understand? I look at the journal and say, well, not much has changed. Do you understand what I mean? It looks like the same journal as when what myself and half a person did it. Grant Blackwell or whoever it was did the. But that's just a history. I'm just saying that has been one of the features that we've seen to expanded, and the knowledge of the smaller states like out here of the college is less than it used to be. But that's just an observation I've made.
Upon reflection, which moment in your career are you most proud?
As I say, I think pride's a bad thing. But if you ask that question, I suppose probably because I pursued a sort of academic career. At the time when I went to radiology, there was just Bill Hare was the only chair of radiology. In those days, to get the title of professor, you actually had to have an academic background. You had to have done a MD or a PhD and written a number of papers. That's changed. I mean, when I get letters from the college, I get Mick Sage, Associate Professor of Radiology, and I realise this person does a few sessions at a teaching hospital. The universities have changed academia, so to say I was proud when I became a professor seems a bit ridiculous now, because we've gone from, well, there was Bill Hare and then there was Jeff Paness, and I took Jeff. There were two, and there was a professor in New Zealand. There were three of us in the whole college. And that was because you actually had to, well, certainly at Flinders, you had to have a certain number of papers and a number of grants. You had to get grants, and you had to have presented a lot, blah, blah, blah. And you had to apply to another group of professors to even get promoted within the system. Then when you applied for a chair, like when Jeff Paness retired, I had to apply to a chair, and there was Bill Hare, there was all these senior people, and a chap had to come from New Zealand. It was pretty full on, to be honest with you. And I remember first applying for promotion from senior lecturer to associate professor many years ago. I was knocked back, even though at that stage I had 50 or so publications, I guess, and it was based because they were judging me on the basis of if I was a physician or a surgeon or a pathologist, and they had much more of an academic tradition. So when you came up to get a job, you actually were promoted. You were on that panel with these guys. This guy's only done 50 papers. Anyway, it sounds silly, but that was what it was like. You're saying pride's the wrong term, but I was aiming for it. I was working towards it, and therefore I had an MD, and I think when I got it, I thought, well, I've achieved what I think I wanted to do, and it was good for radiology. Now, that was back in that stage, there were only three of us, and now, of course, the university's done the right thing. They've said that people contribute, they can change it. It's gone from the days, and it's happened to all the specialties. In the past, to be called professor in our university system, you really had to have an academic track record. I'm talking 30 years ago, 30-something years. It's changed. For example, in the associate professorships, I would say, just in cardiology at Flinders Medical Centre, there'd now be 4 full professors and 5 associate professors. And so they've gone the American way. If you go to America and give a lecture, they'd say, this is Dr. Michael Sage, Professor and Chairman, Department of Radiology, blah, blah. The doctor was the important thing.
Yeah.
That's the thing. So if you ask me what am I most proud of, well, I worked towards that. I knew I had to get a number of publications. I had to get a higher degree. I had to present a lot. And it gave me a reason to stay in the public sector, which at that stage was not as well paid, etc., as the private sector. But I was pleased to get there, but nothing particularly. If you say what am I most proud of, I think I'm most proud of being a member of the college and getting to know a lot of good, nice radiologists around. I think it may. I hope it hasn't lost that. I think it has. I may be totally wrong, but because the numbers have expanded. I remember going to a meeting in '74 and down in Queenstown of all places, and I don't know how many of us were there. Probably 200, I guess, and. All us young, we got to know all these young New Zealanders and other people, and they then would catch up at every year at a meeting, and then we'd catch up overseas, and so I think I'm most proud of being involved in the college. I think I gave me a wonderful opportunity to be involved, and I was pleased to have been involved. Yeah, that's really it.
Wonderful. Are there any other highlights or lowlights that you'd like to share? Anecdotes, stories?
Oh, right, I don't know. I think not really. My only worst thing I ever did was I was at a president's dinner one day, and John Erica's wife, John Erica comes from Queensland, his lovely wife Elizabeth was there in a white dress, and we're having pre-dinner drinks, and I had a glass of a lovely Shiraz in my hand, and I'm being a bit French in the background. I sprayed my hand, and suddenly I threw this glass all over to Elizabeth's front. So I remember vividly that if you're talking about lowlights, that was definitely a lowlight. And the other lowlight I had was when I was giving a lecture in. I was really talking about pride again. I was asked many years ago to give this named lecture at the American College of Neuroradiologists, American Society of Neuroradiology, which is, again, I got to know a lot of people. It was in Seattle, and I was very proud. I spent hours preparing this lecture. It was back in the days of the slides, before the chip, and I spent hours and hours preparing this lecture. It's going to be the pride of my life, and it was fantastic. And for some reason, I got into Seattle the night before, and I didn't have any breakfast because I was trying to load my slides. I remember at morning tea, desperate for some cake. My body was telling me, sugar, Mick, sugar. Anyway, I got up to give this lecture, and there were all these 1,500 people in front, and I was there, and I had the lecture went on, and they have these bright lights, and they take pictures of you on either side. Don't know why, because the guys at the back, you grab your nose or something. But anyway, the lights were very bright, and anyway, I got to 55 minutes. 55 minutes. I'd struggled, and Helen, my wife, never heard me give a lecture because she just doesn't believe in, she would say, but she thought I'd better come to this one. And she was at the back, and all of a sudden I just stopped. I had a hypoglycemic attack.
Oh no.
And I just fainted in front of these 1,500 Americans. 1,500, what was going to be the lecture of my life? And luckily the chair was a friend of mine from Phoenix. He caught me, and Brian Tress, who's in Melbourne, Brian rushed up, and he thought I was dead. Helen thought I was dead because I was at that stage 58. My mother died when she was 58 with subarachnoid hemorrhage. He thought I'd popped it, so she runs down the front. But a guy, an American neurosurgeon, came up and had a bit of coke. And he said, "Oh, I've just had a hypo." Gave me a couple of sips of coke. And, oh, okay. So you talk about low light. That would be the low light. I tried to recover that night because I was so embarrassed. They had a faculty dinner for me, and I remember getting up and saying, "Well, I guess I'm just a typical low-backers, right back Australian." And that kind of, but that was probably the low light of my life. But I think that I think the highlight has been I've been very lucky. When I took up radiology, I was very nervous because I loved it, but I did get a lot of, I guess my ego took a bit of a bashing because I wasn't a bad medical student, and I think that a lot of physicians generally thought that I should have been doing what they told me to do. But luckily I was rescued, but I loved it. But CT and MR is really just, I've lived through that wonderful period of CT and MR ultrasound and interventional radiology. The latter, of course, has been wonderful to see, but it's going to disappear, I think, from radiology. Yeah. But that's it.
Well, Professor Sage, thank you so much for your time today and being part of this interview and this oral history. The stories you have given us today will go a long way in preserving the memory of the RANZCR archive and assist our upcoming radiologists and radiation oncologists in the future. So thank you very much.
Well, they're lucky to be radiologists. Okay.
Thank you for joining us in this episode of the 90th Anniversary podcast series by RANZCR. Stay tuned for more episodes featuring the remarkable stories of our members. You can find more information and updates about our 90th anniversary celebrations on our website and social media channels. Until next time, thank you for listening and being a part of this milestone celebration.